Hi, I'm Dr. Alyssa Watson, and I'd like to welcome you all back to Clinician's Brief, the podcast, where we explore the conversations behind the content. Today, I'm joined by Dr. Charlie Pye, an associate professor at the University of Prince Edward Island in Charlottetown, Canada. She's here to discuss a challenging case of cutaneous lymphoma in a 6-year-old spayed female American Pit Bull Terrier named Stella. Stella presented with intense pruritus and nodular skin lesions that developed over about 2 months. Dr. Pye is here to kind of walk us through the complexities of Stella's case, as well as help us to understand kind of the unique aspects of diagnosing and managing cutaneous lymphoma in the dog. So, hi, Dr. Pye, how are you doing today?
I'm good, Alyssa. How are you?
Oh, I'm so good, and I'm so glad that you're here. This
Me
is
too.
this was such an interesting case and kind of a sad case, but I do think it's really important to bring these to light and help general practitioners such as myself kind of make sure that we're recognizing these types of cases early. And so I'm just really excited that you're here today. Before we jump into all of my questions, because I have a lot, I was hoping you might just introduce yourself to our audience and tell us about your background.
Yeah, absolutely. I actually grew up so I'm in Canada currently. I actually grew up outside of Canada. I grew up in the UK. I usually mention that because every so often my accent comes out a bit or I say a word that's a little different. I moved to Prince Edward Island, which is kind of eastern Canada, to do my undergraduate degree at the University of Prince Edward Island, where I majored in biology, so my Bachelor of Science. Then I went on to do my DVM, Doctor of Veterinary Medicine degree at the Atlantic Veterinary College, which is also here on Prince Edward Island. Upon graduation, I knew I wanted to specialize. I still wasn't 100% sure, but I wanted to specialize in at that time. I then kind of traveled west and I did an internship at the vet college in Saskatoon, the Western College of Veterinary Medicine, as it was called back then. Kind of during that internship, I did do a few external rotations at the Ontario Veterinary College and the dermatology service there, and I loved it. Like, I definitely found my passion, which was perfect. I had a direction I wanted to go in. I was then lucky enough to be accepted into a residency program at the Ontario Veterinary College in dermatology. At the same time, I did kind of a master's degree. They call it a Doctor of Veterinary Science at the Ontario Veterinary College, and I looked into Pseudomonas bacterial biofilm formation and ways to kind of disrupt biofilm formation as well. When I completed my residency, I did practice in private referral practice in Ontario for I think about 8 years. And then over that time period, I would travel back here to Prince Edward Island to teach the vet students here at AVC, dermatology, obviously. And then in 2018, I was really lucky that I was offered a position as a tenure track faculty member at the vet college, which I gratefully accepted. My family is all here on the island. My husband's family is all here on the island. So perfect place for us to move to. Plus, I have a real passion for teaching. I love teaching vets, students, just regular people on the street, anyone that I can get a hold of. I love to teach. And I was also really lucky that here everyone welcomed me with open arms, and I started the very first ever dermatology service at the college. And for a period, I was actually the only dermatologist in the 4 Atlantic provinces here in Canada. That's not the case anymore. There's one other one in Nova Scotia, but I'm still happily kind of trucking along teaching at the vet college.
That's wonderful. And it's great that you have such a passion for teaching. Dermatology in particular, I think, is one of those areas where there's so much client and communication and client education that goes into helping with compliance and helping these animals over time, because their owners need to understand what's going on, because a lot of times we're treating for their whole life, with these things. So really important. And Prince Edward Island, I swear it's someplace I've always wanted to visit my whole life since I was a little girl watching Anne of Green Gables. And so
Yes.
it's one place I haven't gotten yet, but it is on the list of places that I'd love to go. So
Perfect.
let's go ahead and jump into the case of Stella. I want to talk a little bit about just cutaneous lymphoma in general first, though, because this is one where I think it truly has such a wide range of how it presents, and that can be very frustrating or confusing. I I encourage everybody at home to take a look at this article, because the color, photographs that go along with this case showing these distinctive nodular lesions that Stella presented with are just wonderful. But I will tell you, I have seen cutaneous lymphoma just less than a handful of times in my career. And I vividly remember this one case, and it didn't have lesions like that at all. This dog was almost like completely raw over his whole body. He had hair loss. He was painful. And so that looked nothing like what I saw with the pictures of Stella's case. And so I was wondering if you might, for our audience, just kind of walk through the various gross lesions that can occur when we have a case of cutaneous lymphoma.
Yeah, absolutely. And you're so right. Like, everybody kind of knows cutaneous epitheliotropic lymphoma as the great mimicker, because it can look like so many different things. Personally, I've seen cases with just kind of moderate erythema on the ventral abdomen, all the way up to cases where their entire body is covered with ulcers and encrusting and hemorrhage, and really, really severe cases. So when we look kind of in the literature, there is, I think, kind of four main presentations they speak of. One would be kind of pruritic erythema of the skin, as well as scaling. Sometimes they'll call this exfoliative erythroderma. We also see kind of a second version, which is more mucocutaneous erythema. And sometimes along with that, they'll have depigmentation and ulceration at those mucocutaneous sites. The third one would be a little bit like Stella, where we have these kind of multifocal, sometimes they are a little bit more solitary, kind of plaques and nodules that are forming. And then the fourth one is more of kind of a mucosal disease. We don't see as many cutaneous lesions, and that can be infiltrative and ulcerative. I think in kind of studies, depending on which study you read, but there was a big study done by Dr. Fontaine and some of his colleagues. They noted erythema in about, I think it was just shy of 90% of cases, scaling in about 60%, and then the depigmentation in about half of the cases. Some cases will also have kind of other lesions, like they may have hyperkeratosis of the pole pads in association with cutaneous lesions as well. A little bit more rare, sometimes dogs, again, will only have mucocutaneous lesions or mucosal lesions. For me, if they do have those mucocutaneous lesions or mucosal lesions, definitely makes me a little bit more concerned we could be dealing with neoplasia. The cases that I see obviously have been going on for a little while, and I think that a fair percentage of the ones I see do have mucocutaneous or mucosal lesions in association with the cutaneous lesions as well. I think bottom line is that if you have a dog and your treatment isn't working, or you're not thinking you've got exactly the right diagnosis, maybe we do consider doing a bit of a diagnostic workup, because maybe this is a case of lymphoma. One other thing I should mention too is pruritus. Like, are these cases pruritic? Are they generally not pruritic? So in some of the studies that are out there, only about kind of 40-50% of animals in the studies were found to be pruritic. In my experience, I would probably put that number a little higher. I find that the majority of cases I see are pruritic, but I guess we just can't hang our hat on an individual being pruritic, because we can absolutely see lymphoma where pruritus isn't a big hallmark of their clinical presentation.
And then what about lymphadenopathy? Because, classically you think lymphoma, you think lymphadenopathy. Do we tend to see lymphadenopathy in conjunction with the skin lesions when we're dealing with epitheliotropic lymphoma?
Yeah, so in that regard, it is a little bit unlike other lymphomas, because you're right, we think kind of lymphoma, we think peripheral lymphadenopathy. I think only about kind of 20% of cases are noted to have peripheral lymphadenopathy, so it's not common that we see it, and I would agree with that from the cases I've seen. I don't find it very commonly. Metastasis in general is fairly uncommon with this type of lymphoma as well. I mean, definitely there are reports in the literature where there is disseminated disease, metastasis, I think spleen, bone marrow, obviously lymph nodes as well, but it's not impossible, but it's not very common. There is another type of the lymphoma, or another kind of, I guess, subvariant is probably a better way to put it, called Ussery syndrome. And they see this in humans with epitheliotropic lymphoma as well. And with this Ussery syndrome, individuals have cutaneous lesions, but they also have these Ussery cells that are noted in the skin and in the blood. And these Ussery cells are basically lymphocytes. They have kind of hyperconvoluted nuclei. They kind of look a little bit like a brain. That's been reported in dogs, and those individuals more commonly have a peripheral lymphadenopathy, but again, this is not the most common kind of variant of canine epitheliotropic lymphoma.
So you said we can't hang our hat on them being pruritic.
Mhm.
We obviously can't hang our hat on them having a peripheral lymphadenopathy.
Yep.
What about just other systemic signs of illness? I remember, like I said, that one dog whose skin was just so raw. He was sick too, like ill, didn't want to eat, those things. So do we typically see systemic illness with these cases?
We can do. I've seen patients who have cutaneous lesions. They are exceedingly pruritic, but other than that, they're actually doing okay. The owners don't have too many other concerns. I've seen animals other end of the spectrum that are lethargic. They're off their food. They've had, vomiting and diarrhea. So those kind of non-specific signs that we think about when we think an animal's kind of quote unquote unwell, I guess. So can we see them? Yes. Do we always see them? No. I think as well, some of it may just come from the fact that if owners are reporting the animal's a bit more lethargic, if we're thinking, hey, this is an animal who does have quite a lot of pruritus, maybe they're up at night licking and chewing and scratching, so they're not sleeping as well. Owners may report that they have kind of behavioral changes. Maybe they're a little kind of crankier than they usually are. I mean, you know what it's like if you have kind of a really bad sunburn, your skin's almost on fire, you're probably not sleeping as well, you're uncomfortable. Of course, your mood is going to change as well. So that might be something else that people report. But yeah, in regards to systemic signs, we kind of can't hang our hat on that either.
Let's talk a little bit about terminology, okay? Because I do get a little confused about the distinction between epitheliotropic lymphoma and non-epitheliotropic lymphoma. Also, when I graduated, people threw around the term mycosis fungoides. So is that still a relevant term? Sometimes these things change very significantly over time as we learn more about disease processes.
Yeah, absolutely. So I'll start with kind of the mycosis fungoides term. So this term really comes from the human literature. So when we look at cutaneous epitheliotropic lymphoma in humans, they will break it down into mycosis fungoides, the Ussery syndrome, like I already mentioned, and then another one called pagetoid reticulosis. And again, they're just kind of different variants with slightly different kind of signs, such as, the Ussery cells in the blood that you maybe wouldn't see with the mycosis fungoides. So I think kind of the canine version that we see most commonly, where we're not necessarily seeing any changes in the blood, we're not seeing a lot of metastasis. I think that's pretty similar to kind of the human mycosis fungoides. And so that's where the term comes from. I'll be honest, when I'm talking to students, I don't use the term mycosis fungoides a lot. I mention it, but I usually just say canine epitheliotropic T-cell lymphoma. So again, I think that's more of just a term that's used in human literature that was brought over to veterinary medicine and is used here and there, and it is used in the literature as well, for sure. As far as epitheliotropic versus non-epitheliotropic, so there are some similarities and there are some differences between the two. Similarity-wise, they both can be due to kind of T cells, although the non-epitheliotropic version can also be due to B cells as well, less commonly, but it is possible. When we look at kind of epitheliotropic lymphoma, it has that name because there's this tropism of the T cells for the epidermis. That just basically means the T cells like to go into the epidermis. We don't see that with the non-epitheliotropic, hence why it's called non-epitheliotropic. We tend to see more of those T cell aggregates in the dermis and then every so often in the subcutaneous tissue as well. When we look at the type of T cells that are present, they again are relatively similar between the two. So with epitheliotropic lymphoma, we see mostly kind of CD3, CD8 markers, and it is known to be a disease of CD8 positive cytotoxic T cells. And again, CD is just kind of a marker that's found on different subtypes of T cells within the body. Non-epitheliotropic lymphoma is definitely a lot less common than epitheliotropic lymphoma in dogs. Cats, it tends to be a little bit the other way, but focusing on dogs, epitheliotropic lymphoma is by far the most common. There was a study that was done, I think, at UC Davis, and they were, again, just kind of confirming that with the non-epitheliotropic version, we do tend to see more of those T cells within the dermis and the subcutaneous tissue as well. So again, some similarities. Clinically, they can present very, very similar, but then some differences in kind of where those cells are being found and sometimes the cellular populations themselves.
Cats, they've always got to be different, don't
I
they?
know, right? Make our lives that much harder.
I was just interested when Stella came in, what other differentials besides epitheliotropic lymphoma were considered?
Yeah, great question, because obviously looking at her, you can't definitively say this is definitely a case of epitheliotropic lymphoma. So for me, anytime we have kind of nodular or plaque-like disease like Stella presented with, lymphoma is always on my list, as it should be. But other things we would have on there would be maybe deep-seated infections, like a deep bacterial or fungal kind of granulomatous type syndrome, paniculitis, which can be immune-mediated, can be infectious inflammation of the subcutaneous tissue. With that, the nodules usually start actually not alopecia. They still have the hair there, but then over time, they can kind of ulcerate out. Could we be dealing with the cutaneous adverse drug reaction? Because we know those can look like anything as well. And we know, especially by the time cases get to me, there's usually been some medications that have been started or tried, as was the case with Stella. We could see sometimes nodular diseases due to certain types of parasites, histiocytic disease. So lots of different potential kind of diagnoses on that list. And I think that's where the biopsy is such a great option for these cases. Anytime I have a nodular dermatitis, I definitely am kind of gravitating towards biopsy. Yes, absolutely. I'm a dermatologist, so I'm still recommending doing my cytology and my minimum database and things like that. But biopsy can be a really useful tool with those cases.
Yep. Actually, that leads perfectly into my next question. So just as you were just alluding to, Stella, before she came in to see you, she'd been treated with several medications, kind of standard atopy treatments. I think she had been on a course of antibiotics, cephalexin. She'd been on oclacitinib, but also had been on anti-inflammatory doses of prednisone. And so I had questions about that with your diagnostics because, just as you said, biopsy was really your next step. So were there any concerns with the biopsy or the timing of the biopsy because of her previous treatment?
Yeah, another really, really good question. So, in an ideal world, and if we look at kind of a lot of the literature out there, we recommend doing biopsies when patients are not on steroids, just so that if there were going to be inflammatory cells within the skin at any epidermis, dermis, subcutaneous, any level, if we have an anti-inflammatory on board, we may not see those on our samples. If we can't get them completely off steroids, we generally recommend tapering down. That being said, I have personally biopsied a lot of patients while they're on prednisone or have just very recently come off of prednisone or prednisolone or any other types of steroids. And in those situations, usually I'm still seeing very overt lesions despite the use of the anti-inflammatory glucocorticoid. So for me, I think that it's going to be a little bit case dependent. Again, in an ideal world, if we can safely get them off the steroid or taper it down, they're not suffering, and we can maybe see some of those lesions coming back if they fully resolved with steroids, then obviously that would be the route you'd want to go. You don't want to biopsy, skin that looks a bit more normal, doesn't look too inflamed. You want to biopsy lesions. But if despite the steroid therapy, we're still seeing a lot of those overt lesions, which we were in this situation, then that's kind of why I was comfortable biopsying despite that steroid use within her history.
Okay. And then you just kind of said you wanted to go for an area that had lesions, which was another one of my questions. How do we decide where we want to biopsy? Stella obviously had these nodular lesions, but if you had a case that's more diffuse, what do you have specific places that you like to biopsy? I mean, I know like pemphigus, we always think, oh, maybe the paw pads or something like that. Do we have that with cases of cutaneous lymphoma?
Yeah, so when I'm thinking about where to biopsy, I mean, first off, I'm just thinking, where are the best, most active lesions? I know with biopsies, we always talk about biopsying primary lesions if you can, with things like, pustules, etc. Obviously, this is not a disease where we see a lot of pustules unless they have a secondary infection, but obviously we would like to treat any secondary infection before we biopsy as well, just so we're not muddying the waters. We're cleaning up some of the inflammation in the skin so the histopathologist can accurately kind of assess what's going on in the skin and hopefully give us the diagnosis that we're looking for to be able to diagnose and then treat our patient. So for me, in Stella's case, I had so many different areas I could potentially biopsy, so many of these, I hate to say lovely nodules, we know with the outcome of the case, but that is a really, really nice lesion for us to be able to biopsy. If we had a situation where maybe we had a couple of nodules, but then we also had that more exfoliative erythroderma, so kind of exfoliation of the skin cells. Maybe you would take a sample from a nodule and from one of those areas as well. So for me, whenever I'm doing biopsies, I generally take a minimum of kind of 3 to 4, as long as it's not one singular lesion. Obviously, then you're going to be a little bit more limited. But when it's more generalized or multifocal, like hers was, absolutely lots of availability to take 3 or 4. One lesion I don't recommend biopsying would be a full-blown ulcer. By the time we get an ulcer, and I teach my students this all the time, by the time we get an ulcer, we've actually lost the epidermis at that area. So if we biopsy through the ulcer, we're kind of only giving our histopathologist 2/3 of the picture. And maybe if there are things going on in the epidermis, like there would be in cases of cutaneous lymphoma, we want to make sure we provide them with that tissue so that they can look at it and help us out, right? Give us that diagnosis. So for me, I think where I biopsy is going to depend the lesions that I'm kind of dealt with with whatever the patient is showing me. If I have different lesions, I'm probably going to sample those different lesions. Again, that minimum of 3 to 4. I'm unlikely to kind of biopsy directly through an ulcer. Again, we don't have that epidermis, so that's not going to be great as far as getting all the information we possibly can about the skin. And I think that, something else to always consider when you're thinking about biopsying is, and I alluded to this before, if you have a case and you think maybe this is an atopic individual, it's not responding to what you would consider appropriate therapy, you've tried a few different types of atopic dermatitis kind of therapy or any kind of skin disease and it's not responding, biopsy is always a really nice tool to get you that information. Worst case scenario, we think it's an atopic individual, not responding to therapy, we biopsy and we get confirmation this actually is, an allergy. At least then we still know. And we know that maybe we just need to kind of keep trying with, luckily, a lot of the different therapies we have nowadays for atopic dermatitis. So I think just always kind of thinking if things aren't going according to plan, maybe biopsy is a good idea to see if there's any more information you can get. Let's face it, we can't see into the skin. It is nice we can see the top part of the skin, but we can't see any further than that.
Could we talk just briefly about how to prep the skin? And we do such an amazing job, I think much better than we used to, about thinking about pain and anxiety in our patients. So are they sedated? And specifically, if and when we're using local blocks, I always have a little bit of concern about where to put that, where to actually inject the local anesthetic so that I'm not disrupting my cells and making the histopathology results confounded or making my pathologist's job harder because their job is already so hard.
Yes, especially with skin, because it can be pretty challenging. So I agree. Obviously, we want these guys comfortable when we're taking the samples. So for me, if I'm thinking of doing biopsies, definitely sedation. First off, certain areas of the body, I would maybe even consider general anesthesia to take the block, and those would to anesthetize the patient, and those would be areas where we don't really have the best chance to do a local anesthetic. So I'm thinking of maybe like the nasal planum, pole pads, or an area that we just don't want any movement in our patient. So usually if I'm taking biopsies of the ear pinna, I'll place a patient under general anesthesia, obviously a pretty short one, thankfully. If it's kind of on the flank or the dorsum, along the limbs or something like that, then usually I'm going for sedation as long as it's not contraindicated in the patient. And then I am pairing that with local anesthetic. I'm generally using lidocaine. I like to mix my lidocaine with a little bit of sodium bicarbonate, just kind of takes the sting out of the lidocaine because it can sting a little bit when you inject it subcutaneously. And just like you said, Alyssa, we want to make sure we are getting a subcutaneous injection. We don't want to inject between the layers of the skin, like an intradermal injection, because that is going to change the architecture of the cells. So whenever I'm blocking, I do just what I would do for any subcutaneous injection, kind of put my needle in, draw back, make sure I'm not getting any blood, make sure that, I'm not getting a lot of resistance there. And then going to just basically put a little bleb of the lidocaine under where I'm looking at doing my biopsy. I think some people maybe do more like ring blocks or fan blocks. I tend to just do kind of a bleb right while I'm taking my biopsy, let it sit for a few minutes so that hopefully my lidocaine will spread out a little bit, and then I would proceed with the biopsy. So again, kind of in summary, I guess most cases sedation and then a local block. Certain cases where a local block maybe we're not able to do, then I'm going to elect more for general anesthesia, just so that my patient's a little bit more comfortable. Nobody needs to feel a biopsy punch going into their skin if we can help it.
Yeah, perfect. Any other just tips or tricks for making sure our pathologist gets all of the info they need?
Yeah, so my usual just recommendations whenever we're thinking of submitting a biopsy sample is just try and give the histopathologist as much information as you can. And you don't have to be super, super lengthy, but maybe give them a summary of what's been going on. I like to give them kind of my derm exam findings as a little summary so they get more of that kind of visual picture in their head of what the animal actually looks like clinically. I usually will send our histopathologists at the college. I'll snap some pictures for them as well. They love that because they don't often get to see the animal itself. They just get to see the tissue that's placed in front of them. And I know that they really appreciate that. I've had conversations with our histopathologists where they haven't been giving a lot of history. They've maybe just been given, pruritic dog. And it's really nice for them to get a bit of history because then they just, can do this, putting these pieces of the puzzle together for us and searching around. Is there some kind of deeper tissue we want to look at, et cetera, et cetera. So I always do kind of a brief summary of what's been going on, a brief kind of description of my derm findings, maybe snap some pictures and send to them. And then hopefully that will give them as much as I possibly can.
Another place where I think technology has just really helped us with the ease to be able to snap digital photographs and email those or send them along with your case. So that is one of the nice things about some of the technology we have now.
Absolutely agree.
You're busy. Your CE needs to be easy to earn and easy to track. Clinician's Brief CE is highly relevant and now more convenient than ever. Study online, from home, or on the go, and always at your own pace. Courses are RACE approved and designed with your busy schedule in mind. Start your next course today at cliniciansbrief.com/CE. So now that we talked a bit about how we're coming to this diagnosis, let's talk about treatment. So sometimes epitheliotropic lymphoma can be treated surgically, but not always. So what factors help determine whether a patient might be a candidate for surgical treatment?
So surgical treatment usually is reserved for more kind of focal lesions, especially if there's no metastasis. Again, that's not exceedingly common, but it's not impossible. Or it could be maybe palliative if there is metastasis present. Obviously, in a case like Stella's, and she's a prime example where we've got these multifocal lesions, trying to do surgery on her is going to be very challenging because we've got so many nodules that we have to try and remove. And then we're going to have enough kind of skin to close our surgery sites, etc. So generally more those focal lesions, or maybe just, one or two lesions, minimal lesions, let's put it that way, that are more focal. And when there are focal lesions like that, surgery can be very helpful for our patients. If they have even just like single mucocutaneous lesions, maybe we consider more of a surgical approach there. Getting rid of that little tumor that's there is obviously going to help with their survival time as well.
Yeah. And then if an animal is treated surgically, do you usually follow up with chemotherapy as well? Or can these be one surgical procedure and done?
Yeah, I think depending on kind of margins, just like any type of neoplasia, it may be that the surgery is all that we need to do and we don't need to follow up with anything else. Obviously, there's going to be some cases where we're not as able to get good margins. We may need to follow up with chemotherapy or radiation therapy or something like that. Both of those are medical options for this type of lymphoma as well. So I think, yes, it would depend a little bit on whether you were able to get good margins.
Okay. All right. And you already said Stella's lesions were very, very diffuse. Surgery was not an option really for her. Chemotherapy was chosen instead. From my homework that I did, not just reading the article, but a little bit, into some of the questions that I wanted to ask you. It looks like lomustine appears to really be the most commonly utilized chemotherapeutic option. But what other medications have been tried? And are there anything else that people have used with success?
Yeah, so there are definitely a few other kind of treatments in the literature. You're absolutely right that lomustine is usually the one that a lot of dermatologists at least will gravitate towards if again, surgical removal is not an option. Tends to be the one that there's more studies on, maybe slightly increased response rates, etc. But other things that have been looked at, I already said radiation therapy can be used in certain situations. Studies, I think, for radiation therapy around 70% kind of success, depending on the study that you read. Other oral medications that can be used that are out there in the literature. Retinoids, there's definitely a few studies looking at retinoids. I think retinoids, the response rate is a little lower, maybe around 50%. Again, it's going to depend on the study you read. However, they can be a little bit challenging to get a hold of. Side effect wise, there's kind of a plethora of those, and we extrapolate a lot of those from what they have in the human literature. I think a lot of the studies, on retinoids, survival time is not necessarily longer than some of the other therapies either. There are a couple of kind of single case reports out there. So there's a case report using dacarbazine. It's used for humans with neoplasia as well. They did kind of 3 cycles of treatment. Forgive me, I don't remember exactly what a cycle entails, but they did find complete remission in that, again, one case report. So a small number, obviously. There was also a case report looking at the use of oclacitinib at a higher dose than we would think of using for just your regular kind of itchy atopic patient. In that study, they did find in the dog increased pruritus, increased lesions. The dog felt a little better as well. They found fewer neoplastic lymphocytes in their skin samples as well. There's also one kind of study, I think it's out of Europe somewhere, if I'm remembering correctly, where they actually used very, very high doses of safflower oil, and they found that I think 6 out of 8 dogs in that study had an improvement in their clinical signs as well. Again, very, very high doses of safflower oil. There's another few studies with L-asparaginase as well, with varying reports of success. So there are definitely lots of other reports out there of different treatments that can be tried and maybe more on the horizon, right? Again, we have kind of those N of 1 for things like oclacitinib. Maybe, if more people kind of use it in some of these cases, we make it a little bit more information there, positive or negative. And I think that's the downside of some of these studies is they are just single case reports.
Yeah, it does sound like lots and lots of things have been tried. Are there utilities for those medications, even if we don't expect them to induce remission, the way that we traditionally are striving for with chemotherapy? Can they be used palliatively, like you said, oclacitinib or even doses of prednisone?
Yeah, and that's also something else we have to consider, right? It's just the quality of life of our patient. Maybe the owners don't necessarily want to put the animals through chemotherapy or surgery or anything like that, but they sure as heck want their pet to feel better, just so that they're happier at home for whatever time they may still have with their family. Definitely, there's anecdotal reports out there of prednisone, oclacitinib, also lokivetmab, all helping to kind of reduce pruritus and make patients a lot more comfortable. In human medicine, when humans have cutaneous epitheliotropic T-cell lymphoma or any of the variants, they will commonly use topical glucocorticoids on the skin, and they actually find quite a good response rate with that, as from what I've read. There are some literature reviews out there. Most of them kind of find that prednisone alone doesn't necessarily lead to remission. But again, if that's not what we're looking for, and we're looking for more comfort, we can see some improvement of the pruritus in those predic individuals or some inflammation as well.
Kind of leaping off of that, I know when I have more traditional lymphoma, with lymphadenopathy and everything, I always talk to owners about we can start, prednisone, and likely help bring these lymph nodes down and make your pet feel better. But it might affect us if you then change your mind and do decide to go for full chemotherapy. Do we see that with cutaneous lymphoma as well?
Yeah, that's a great question. And I don't know if I can give you a solid response to that. I don't know if I've necessarily read much in the literature where that kind of order of treatment has been done. I would presume it would probably be be similar, but who knows? Again, this type of lymphoma is not one that responds phenomenally to steroids, so maybe we actually wouldn't see that change in response rate by using the steroids first.
I want to talk a little bit about this relationship between cutaneous lymphoma and atopy, because I was unaware of this before. So, what is our current understanding of the relationship between the two diseases, and this idea that atopy could develop into epitheliotropic lymphoma?
Yeah, so I mean, there was one study by Dr. Santoro, and in that study, and his colleagues, excuse me, in that study, they actually found that individuals, if they had a history of atopic dermatitis, they were 12 times more likely to develop cutaneous T cell epitheliotropic lymphoma, which is obviously a large number there, a large kind of risk percentage, I guess. I think they found the same in humans as well, that there is an increased risk of lymphoma in individuals that have atopic dermatitis or atopic eczema as well. I don't know if we exactly know why that risk is there. People kind of postulate that maybe it's because when we have an allergic skin disease, there's kind of this chronic stimulation of T cells within their body from environmental allergies or anything else that they're having an allergic reaction to, and that maybe then there's kind of clonal expansion of some of those lymphocytes, and maybe that contributes to the development, or they kind of start to have more of that neoplastic kind of infiltrate there. So I don't think we exactly know, but we do know again that that risk is there. In human medicine, there is a lot of data out there looking at the atopic march, and that's basically where individuals who have atopic dermatitis when they're young, they will then potentially get subsequent allergic rhinitis and then asthma kind of later in childhood or into early adulthood. So that's kind of the atopic march. Maybe this is a similar kind of entity to that. Again, I don't think we really know that right now, but the risk is definitely there. And I think that's important for us to know, that if we've had this individual who's had atopic dermatitis and they've been pretty well managed, the occasional flare up, as all atopics do, we all know that, maybe all of a sudden they kind of stop responding to therapy, or they're not responding as well as we hoped, and we maybe change or we maybe increase our doses of things and they're still not responding, which should kind of set something off in our brain saying, hey, like, is this still atopic dermatitis, or do we have one of these situations where maybe this is more of a neoplastic disease process now, and then maybe we do need to biopsy to get confirmation one way or the other. So yeah, it's kind of, I guess, an unfortunate statistic, but I think a really important one for us as practitioners to be aware of.
Sure. And then I guess if our atopic dogs are, so much more likely, or have a much higher risk for developing epitheliotropic lymphoma, does it follow that there's kind of like the same breed and sex predilections for the two diseases?
Yeah, and not really would be kind of my short answer. So there are some studies out there that haven't really found a breed predisposition or kind of a sex predisposition for cutaneous T cell epitheliotropic lymphoma. Others suggest that maybe boxers and cocker spaniels may be predisposed, and I mean, definitely those are two that I would think of allergies in as well. But whether that correlates, who knows? That being said, I mean, I've seen lymphoma in all types of different breeds, and actually not that commonly in those two kind of predisposed breeds. So I think that we just have to rely more on clinical signs slash not really responsive to treatment slash things kind of changing, or if they do have those mucocutaneous or oral lesions, more so than what breed am I dealing with at this time.
Okay. And then kind of wrapping up, we have mentioned a couple times that this case, unfortunately, did end with Stella succumbing to her disease. And so what is the overall prognosis for dogs with cutaneous lymphoma? And do we have any specific prognostic indicators, when they first come in?
Yeah, so the prognosis for the disease in general is fairly poor. It's definitely one, when I get that biopsy report confirming it, I always kind of, have a sigh a little bit that I then have to relay that to the owners. I mean, I've always kind of preempted it, let them know it's a possibility, but it's not the best news to let an owner know, just like with any type of neoplasia. This one in the literature, again, depending on where you read, mean survival can be kind of a couple of months up until 2 years of age. I've definitely seen some really severe cases where unfortunately it has been just kind of a few months at that point in time. In the literature, because there's so many different treatments and some are used a lot and some not as much, some of the studies will say that there's not really a lot of difference in mean survival time treated versus not treated. Some will say that yes, treated, depending on the treatment, you will get a longer median survival time. But in general, yes, the prognosis is not great. It is poor to guard it, depending on how aggressive the disease is and how systemically well the patient is feeling also. To your point about any prognostic indicators, I believe in the literature they will say things like because lymph node enlargement is a lot less common, it's controversial as to whether that's a prognostic indicator or for severity. I think that if they have the cutaneous form with multiple lesions, that's not the best prognostic indicator. If they are treated and they have complete remission, that is associated with a longer survival time, a better median survival time. And actually, that's something I didn't touch on earlier that I would just like to really briefly touch on here is complete remission versus partial remission. So I've mentioned, a few studies that will show, high percentages of response rate, et cetera, et cetera. In a lot of the studies, that's the overall response rate. So that's taking into account individuals who've had complete remission, but also individuals who've had partial remission of the disease as well. That overall response rate. There was some other suggestion out there that kind of poor prognostic indicators would be if you had neoplastic lymphocytes in the blood or if you had dramatic changes on your complete blood count, like a thrombocytopenia or such.
Sure. And I guess just then finally, do you have any tips for, having that conversation with owners, especially if they've treated, I certainly find if we've treated for a long time for one disease and then we come back and say, this has changed, or now this is much more serious, and a potentially fatal change, that can really be difficult for owners to understand.
Yeah, absolutely. And anytime that we have to portray that unfortunate news to owners, it can be very challenging for them to digest and process, especially kind of in that moment there. So for me, again, I usually, if it's something I'm concerned about, even before I do a biopsy or recommend a biopsy, I'm usually laying that groundwork and I'm letting owners know that this is a potential. Hopefully I'm wrong. And then the biopsy either way is their best chance to let us know. Obviously we all know biopsies are not 100%, but it's going to be our best chance. So I'm always kind of preempting it so that if I do unfortunately get that diagnosis, at least they've heard that it's a possibility and this isn't brand new news to them. Obviously, I don't want to scare people unnecessarily, but hopefully at least letting them know it's a potential. If it turns out it's not neoplastic, then that's wonderful. Best case scenario. If it is neoplastic, at least we've laid that groundwork a little bit. And I think just when I talk to owners, I just try and put myself in their position, try and be as compassionate as I possibly can. Try and make sure that I am maybe a little bit, I don't want to say simplistic, but I'm not delving too much into all the pros and cons of all of the different treatments, because I know once they've heard that news that their patient has a their pet has a neoplastic process, that they're going to need a minute, right? So I don't want to deep dive into all of the potentials. I want to kind of give them slightly more basic information. Obviously, we can answer questions later. I generally say to my clients, and obviously this is going to be dependent from vet to vet, I generally say to my clients, I don't want you to make a decision as what you want to do today. I want you to take 24, 48 hours to think this through. I'll often type up some notes for them and send it to them so that when they get home, they've had a chance to decompress. They can pull that out and maybe kind of take a read through some of the highlights because they've probably forgotten it from our conversation. And that way it just gives them a little bit of time to process everything and think things through. Usually then when they come back, they have a few more questions. Maybe the emotions aren't quite as vivid at that point in time because again, they've had a little bit of time to decompress, and then we can just chat about the direction that we want to go. I also try and be very judgmental, and I think we're all like this, absolutely, is that if they do decide that they don't want to pursue treatment and they do feel like humane euthanasia would be the best for their pet, that I support them in that decision. If their pet's very uncomfortable with their quality of life, they're suffering, we know this is not a disease with a great prognosis, then I'm going to support them from that aspect as well.
Yeah, that's very wonderful advice. Thank you so much for just taking the time to talk about that, because I think, we as vets, we focus, so much on how to fix everything. And oftentimes it is important to just remember that this is a journey that we're on with the client, and we need to present all the options and then let them make the best decision for them and their family. So
yeah, absolutely.
Thank you so much. This was a fantastic conversation. Now that we've gone through all of these technical questions at the end of our episodes, we do have a little bit of fun. If you would like to, we have a little game we call Rapid Fire. It's really just kind of a series of would you rather questions that I just shoot off at you quickly and you just answer off the top of your head.
Oh,
do
fine.
You want to play?
Yes, absolutely.
Yeah. Good. Okay. Would you rather practice without topical antimicrobials or without topical steroids?
Without topical steroids, because as much as I love steroids for decreasing pruritus, decreasing inflammation kind of fast, obviously not long-term. Nobody loves steroids long-term. In this day and age of antimicrobial resistance, like topical antimicrobials have a huge position in treatment of skin infections. So I don't think I could practice without topical antimicrobials.
Awesome. Would you rather somebody stole your favorite pen or somebody threw away your favorite blade that you'd been dulled and used for skin scraping for like 2 years?
Oh yeah, that's a tough one because I do like my pens. Oh my gosh, I probably though I think I would be more upset with the blade.
Okay, yeah. All right, that's definitely a dermatologist answer.
Yes, it
is. Okay. Would you rather find out that the puppy that you were just snuggling has scabies or have a client want to show you their rash?
Oh, definitely the first one. I would definitely more like be happier being like, oh, you have scabies. Okay, whatever. Like it doesn't like to live on me. Anyways, it's fine. It's no big deal. It's okay. But I've had so many people over the years show me rashes and surgical sites and dehisced wounds. And I'm scarred forever for that. I mean, we've all been there, yes. Right? But I've been there a lot.
We have.
So yes, I would definitely rather snuggle a scabies puppy than somebody show me their rash. 100%. I'm not a human dermatologist for a reason.
Yeah, and I try to like go back to the I'm so flattered that you trust me that much, yes. But yeah, I don't need to see that.
Yes, exactly.
Okay, would you rather your canine or your feline patients could speak?
Oh, definitely feline. I mean, I'd love to be inside the brain of a cat to hear what they were thinking. Cause you can sometimes tell what cats are thinking, and also just because, with, especially with skin disease where they have the different reaction patterns, but then each reaction pattern has a really long differential list. And then owners are saying my cat's not itchy, but it's got the naked belly. And you're thinking, is it over grooming at night? So yes, I would much rather cats be able to talk to me than dogs.
Cats can give you a much more detailed history than their owners could, I think.
Yes, I think
dogs
so.
Dogs are just an open book.
Exactly.
All right, last question. Would you rather have to do lime sulfur dips on 10 kitten-sized T-Rexes or one like giant T-Rex-sized kitten?
Oh, the first one. At least if they were small, I could maybe try
T-Rexes running around.
Yeah, but maybe I could hold them down. If it's this big T-Rex cat with its claws going, I don't think I want anything to do with that. But I know there are some people in veterinary medicine that like thrive with the fractious cat. I do not thrive with a fractious cat. I would rather a fractious dog than a fractious cat any day. So the thought of a T-Rex sized cat, I don't know, gives me heart palpitations. So I'll take the little guys.
Okay.
Yeah.
Okay. Excellent. Well, that was it. That wasn't too bad, right?
Oh, no, that was great. That was fun. I loved it.
Oh, good. Good. Excellent. Well, we loved having you. I would love to have you on again. So you need to write some more articles for Clinician's Brief.
Okay. I'll get on it.
Okay. Fantastic. I just want to say thank you so much to our audience for joining us. And we hope to have you back in the future.
Thank you so much.
Thank you for joining us for today's episode of Clinician's Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinician's Brief, the podcast is a VetMedics production, produced by Alexis Ussery, and hosted by Dr. Alyssa Watson.